Okay, so first we're going to take a look at the thumb ulnar collateral ligament test. So you're going to want to hold metacarpal 1 and the proximal phalange of the thumb. And this is going to be a collateral ligament test. So you're going to be applying a valgus or varus force depending on the orientation, looking for excessive motion. In this case, there's not really excessive motion in this case. Everything looks pretty good. You can check opposite directions, of course, looking for that motion. And you also want to check in 30 degrees because of the nature of the saddle joint. The orientation will change. So keeping a good force. It's really easy to isolate the joints in the hand just because of how easy they are to actually grab. So going through this test, not particularly bad. Next, we'll take a look at the lunotriquetral test or Reagan's test. So we're going to palpate the triquetrum and the lunate. Lunate going to pop into your finger when you go into extension. And by stabilizing the triquetrum, in this case I'm going to stabilize it on the table with my hand, I can glide the lunate anterior and posterior, or dorsal ventral, however you exactly want to term it. But I can perform those glides on the lunate, and I'm feeling for motion, pain, and crepitus. So as far as motion goes, I'm looking for motion equal to about half the carpal body. That's what we're terming excessive motion in the case of all these tests. And so, of course, patient's impression will determine whether that's positive. From motion, crepitus, or pain, you'll be feeling crepitus, you'll be feeling motion, the patient will be feeling pain. The next thing we want to take a look at is going to be the dorsal capitate displacement apprehension test. Just rolls off the tongue. So you want to be thumb over thumb on the capitate. It's going to be the base of the third metacarpal. So right there we go. Thumb over thumb on the capitate. Posteriorly, I don't want to block it because I'm going to be pushing it into the posterior surface of the hand, feeling for that motion, and of course also feeling for crepitus or displacement or pain. Those are going to be positive indicators. And so that's going to be our first look into some tests for the hand. Okay, so next we're going to take a look real quick at the scaphoid shift test. So this is going to be performed by starting an ulnar deviation with a anterior pressure on the scaphoid with a stabilized wrist. You're going to bring the hand into radial deviation, and when you release the pressure of the scaphoid, it'll move anteriorly or in the palmar direction. And a positive test is going to have a audible clunk at in range. So that's going to be it coming back into the position depending on whether or not it has instability. So start with a firm block, move fully radially, and releasing pressure. No clunk, motion seems smooth, so it's going to be a negative test. Okay, so now let's take a look at the Allen test. It's a test for arterial refill of the hands, looking at circulation and collateral circulation through the radial and ulnar artery. So first things first, you're going to have your patient supinated, arm supported, and you want them to make a fist, contract and relax their hand quickly 10 times. 2, 3, 4, 5, 6, 7, 8, 9. And on the 10th one, you want them to hold and squeeze. There we go. Perfect. Okay. And go ahead and relax. So you're going to block the radial and ulnar artery. And then we're looking at when I take my hand, or when I stop blocking one, you want to look at the rate of refill. And so, of course, going through your deep and superficial palmar arches, it should refill the whole hand, but you're obviously going to see a perfusion in one side of the hand faster than the other based on the one that you disocclude. And you're looking for a refill time of less than 2 seconds to indicate competent circulation and refill. And so, of course, if you have one side, say the radial side, refills slower than the lateral side, or than the ulnar side, one excellent thing you can do, and something you should always be doing in all these tests, is testing contralaterally to see what is normal for the body. That's going to cover it for the Allen test. So we're going to take a look at a couple other functional hand tests looking at just various aspects. We're going to start off with the Finkelstein test, which is going to be for Descarves's tenosynovitis, but it also looks at inflammation of the long thumb musculature and can show some symptoms with the extensor carpi radialis longus and brevis, potentially. So to perform it, you're going to tuck your thumb across your palm, make a fist around it, and keeping your hand straight, you're just going to ulnarly deviate. It's going to be a pain provocation test, and this one's pretty well done just by the patient themselves, having the patient go through the motion. It could be repeated motion that's going to cause, that's definitely going to increase the odds of causing inflammation through that tendon and this tendinal sheath. And you're also going to, you can create positive tests just by doing this test a lot, because putting the tendons and structures really on that much tension right there can potentially cause inflammation of false positives. So definitely one you want to test conservatively as far as dosing. You don't want to do this 5 or 6 times with your patient, because you can just artificially cause a false positive, and it can be uncomfortable for patients that actually don't have a symptomage corresponding to it, just depending on how the tonicity of their muscles and the anatomical position of the joints. Next, we're going to take a look at just Tinel's sign. So we've done this before in the lower extremity. We've done it in the elbow. Now we're going to look at it on the wrist. And of course, if you did this up the chain somewhere, you could still have positive reproduction of symptoms down the chain. So if you did it in the elbow, if you did it very firmly in the shoulder, you may get signs in the hand regardless, but you can always test at the hand, at the wrist. So with your 3 nerves, the radial, the ulnar, and the median nerve being the ones that are innervating the hand, we want to go through and test each of those. So your ulnar nerve is running just medial to your pisiform here on the ulnar side of your palm. So a good 4, I'm going to stabilize my hand here a little bit, a good 4 to 6 taps. Looking for reproduction of symptoms, tenderness, numbness, anything down the chain, potentially even up the chain. It's negative for me. I don't have any real neurological symptoms in my upper extremity. Then I can come over to the median nerve, which is going to be on the radial side of the carpal tunnel, right through here. There we go. So again, another negative. And of course, it doesn't really matter how you could do it. You could tap 4 times or 10 times. It doesn't really matter how many you tap, as long as you are appropriately performing the impact and getting the appropriate percussion of that. That's the most important factor. Doing it 10 or doing it 4 is not going to change whether or not the symptom's going positive or negative. And finally, we can do the radial nerve. The radial nerve is going to be running just medial to the snuff box, medial towards the midline of the hand, towards the 3rd metacarpal. And so just taking a look at the snuff box, going a little bit medially. It's going to be right in there. And so with a good block under my hand, I'll just... Still negative, but that's just running through Tinel sign again for a different part of the body. Next, we're going to look at the Fromen's sign, F-R-O-M-E-N-T, which is a little bit of a funny spelling for the pronunciation, but Fromen's sign is going to be having the patient hold a piece of paper between their thumb and their lateral index finger. So in that pinch grip, the lateral pinch grip specifically position, holding the piece of paper in there, and you're looking at the way of which they hold the paper and maintain their grip on the paper when you apply resistance. So in this case, I'm going to use a lateral pinch grip on the opposite side as well to pull. And you're looking for whether or not they use distal flexion or proximal flexion of their thumb to achieve the grip. And so when I say that, I mean whether or not they have a straight thumb holding due to an inability to flex the interphalangeal joint of the thumb and maintain that pressure, or whether or not they can achieve that thumb flexion. And so this is it can be a test for neurological deficit, It can be a test for weakness, it can be a test for atrophy, it can be a test for a lot of things, but it's going to be incredibly indicative of a limitation in thumb function and grip strength, and definitely functional ability if a patient has a positive Frohman's sign. Okay, so let's take a look at a few more tests for the hand. So the first one we're going to look at is a test for the integrity of the central slip, and so this is going to reveal a complication with the attachment of the central slip on the dorsal side of the finger. It would also reveal a boutonniere's deformity. That's kind of the setup that you're looking for, which is going to be a flexion of the proximal interphalangeal joint and extension of the distal interphalangeal joint when positive. So what you're going to do is you have your patient with a finger over, or in this case off of, the firm edge of a surface. I've got a little green box here that I'm using. Normally what I attach my GoPro to, but this is going to be my tool in this case. So I'm going to resist extension. And so what's going to happen is my finger is going to extend. And you can see my proximal interphalangeal joint going into full extension into a locking position, and you can see actually the tendon coming across the top there. So this is a negative, but if we were going to have a positive, I would have this result. So that would be the extensor tendon coming off to the side and creating a shortened path laterally around the joint, and that also causing a hyperextension of the distal phalanges in order to create the straightest path to the tendon to apply pressure. Next, we can take a look at the ulno-menisco-triquetral dorsal glide. Really rolls off the tongue there. So for that, I'm going to modify my positioning a little bit. I'm going to stabilize my ulna right here, as you can see. We're going to push my ulno-menisco-triquetral region dorsally, looking for hypermobility or pain. So with a good golfer's grip, always come back to that. Relaxing my hand, I can push that dorsally. And I don't have any pain, but if we get a good lateral view, you can see that my forearm starts with my hypothenar eminence pretty prominently forward, and with a good firm grip, I do have a lot of posterior motion. And there is a little bit of a clunk sensation when it heads dorsally. So this interpretation of that could be a little bit up in the air. It's looking for hypermobility or pain. Definitely more in the region of hypermobility for the case of my test. Pain, negative, and I don't have any real wrist stability issues clinically. So with my clinical judgment, I would call that one a negative test. Next, we're going to look at one more done on me. And that's going to be the scaphoid stress or compression test. And so that's looking at an axial load through the scaphoid done through both my thumb and my second metacarpal. And so this is going to be looking for pain. This could show a stress fracture or irritation, inflammation, anything like that, hypomobility. But the test itself is pain provocation, so it's looking for pain. So first things first, get a good firm grip of my my thumb and apply a axial load into my hand. I'm just using my arm to stabilize currently, but it could also just be done with hands stabilized on the table. Good axial compression, and so with a negative there, I can move on to my second metacarpal here and apply another axial compression, both of those coming back to the radiocarpal joint and the scaphoid being the primary bone of that articulation. Okay, so finally we're going to take a look at two more tests, the Phalen's and reverse Phalen's test, and then we're going to take a look at the different kinds of functional grips in the activities they'd be used in. So first things first, we're going to look at the Phalen's test, which is going to be taking your hands, flexing them all the way, and putting them back to back. You're going to maintain this position for upwards of 60 seconds, and this is looking for a reproduction of symptoms through the extensor musculature on the dorsal side of the hand. Very similarly, and exactly the opposite, the reverse Phalen's test, a similar position, exact opposite muscles that we're testing. going to be in more of a priest's pose or a prayer pose. And you're going to hold this for same time duration, 60 seconds, looking for reproductive symptoms. In this case, stretching the flexors and looking for reproduction of symptoms there. Next, we're going to take a look at different kinds of grip. And so we've got three main kinds of grips that we're going to look at. We've got the power grip, the prehension or precision grip, and the lateral pinch grip. So I already talked a little bit about the lateral pinch grip going through some of the testing earlier. When we look at the lateral pinch grip, it is going to be the compression of your thumb and your lateral phalange as a way of holding. So think about handing somebody your credit card, or maybe flipping a page, picking up something fine. Typically you think about holding paper or holding cards like this. Like if you ever play Uno, you're going to use a lateral pinch grip. No one's going to use a power grip to play Uno. Next, we'll look at the power grip. So the power grip is going to be using the fingers, thumb, and palm to squeeze something. So that would be a conventional stress ball power grip. If you palm a basketball, it's a power grip. Holding a wrench, holding a cup. Other companies are available aside from Popeyes. And so that's going to be high force, low precision. You can generate a lot of grip strength that way, and that's the way the most grip strength tests are done. I believe it's referred to as position 2 with that 90-degree angle and really focusing on that power grip. But as far as doing something like maybe unscrewing a small screw or handing someone the paper, you don't need that much power, so you're going to use other forms. Finally, we're going to take a look at the precision or prehension grip. Either or terms are interchangeable. This one's going to be what you would think of for using a paper or maybe typing. This is, if you were gripping the keyboard, this is going to be your thumb and the tips of your fingers. The most common thing you would think of is holding a pin. This is not a pin, this is a Allen wrench. But turning an Allen wrench can be done with a prehension or precision grip. When you insert a Allen wrench into a socket, you do not do it like this. You do not do it like this. Probably you're going to use a precision grip to have the control, the fine motor control, to actually put it into the socket and be able to turn it. And so that's going to cover our three different kinds of grips and some of the functions for them. And so assessing those would be just done either through some standardized protocols, which are readily available out there, or through looking at the patient's ability to repeatedly pick something up using a given grip or their strength in a given position. And that's going to cover it for our assessment skills for the hand and wrist.